Welcome to the Kanski lecture series, and we are going to start about the eyelids chapter 2. And in this part, we are going to study about the anatomy. So, first, anatomy consists of skin, which consists of epidermis, dermis, and related structure. Epidermis comprises, so in this eyelid part, we are not going to discuss about the eyelid structure. We are going to discuss about the skin of the eyelids first. And in the eyelid skin, the first part is epidermis. The epidermis comprises 4 layers of the keratin producing cells, keratinocytes. It also contains melanocytes, Langerhans cells, and Merkel cells. The layers of the epidermis around the eyes are described below. Cells migrating superficially, undergoing maturation and differentiation through the successive layer. So basically in epidermis there are 4 layers, and every layer have a keratin producing cells. It also have contain other cells such as melanocytes, Langerhans cells, and Merkel cells. So what happens is basically the base layer cells migrate superficially and they undergo maturation and differentiation through successive layer. So we have 4 layers: keratin layer, granular cell layer, prickle cell layer, and basal cell layer. So first is a keratin layer, stratum corneum or horny layer consisting of the flat cells devoid of nuclei. Granular cell layer, stratum granulosum, typically consist of 1 or 2 layers of the flattened cell containing keratohyaline granule. Prickle cell layer, stratum spinosum, is approximately 5 cell deep. The cells are polygonal in cross section and have abundant eosinophilic cytoplasm. Their free borders are united by the tiny spiny appear desmosome cellular junction. Basal layer, stratum basalis, comprises a single row of columnar shaped proliferating cells containing melanin derived from the adjacent melanocyte. So it's clear that we have a 4 layer. So first layer is known as a basal cell layer, or which is also known as a stratum basalis, and it is a columnar cell layer, and it also has a pigment, and the cells containing the producing the pigment which is known as melanocyte. So above this is a layer of the prickle cell layer, or a stratum spinosum. It is a 5 cell layer deep, 1 2 3 4 5, and it is polygonal in cross section. And what does it do? That it unite each other with a tiny appearing desmosome. Above this is a layer of the granular cell layer, or known as stratum granulosum, and it consists of the flat cells, 2 layers of the flat cells, and it contains the keratohyaline granule. The superficial cells are flat cells, and they are also devoid of nucleus. They are known as keratin layer or the stratum corneum. The dermis is much thicker than epidermis. It is composed of the connective tissue and contain blood vessels, lymphatics, and nerve fibers, in addition to fibroblasts, macrophage, and mast cells. Upward dermal extension papillae interdigit with downward epidermal projection retirages. In the eyelid, the dermis lies on the orbicularis muscle. Adnexa lie deep in the dermis or within the tarsal plates. So in a case of a dermis, basically dermis consists of the connective tissue. It also contains lymphatics, blood vessel supplies, and also some mast cells, macrophages. So there will be the upward dermal extension, which is known as papillae, that will indicate the downward epidermal projection known as retirages. So there will be the certain kinds of the glands that can be present in the dermis. There can be the sebaceous gland, meibomian gland, gland of Zeiss, gland of Moll, eccrine sweat gland, and the pilosebaceous unit. So first of all, we will discuss about the sebaceous gland. Where it is present, it is usually located in the cruncle and within the eyebrow hairs. The sebaceous glands are located in the cruncle and within eyebrow hair. Tiny sebaceous glands are associated with the thin vellus hair covering the periauricular skin. Meibomian gland. So one of the most important gland is the meibomian gland. It lies within the tarsal plate. So tarsal plate is basically, we have an eyelid, and eyelid is divided into 2 parts known as anterior lamellae. So this is an eyelid margin, So you can say it is divided into two parts, anterior lamellae and posterior lamellae. Anterior lamellae is further divided into skin and orbicularis muscle, and the posterior lamella consists of the tarsal plate and conjunctiva. So within this tarsal plate layer is the meibomian glands, and um, they exit through the orifice in the posterior laminae. Meibomian gland are the modified sebaceous gland found on the tarsal plate. They empty through the single row of 20 to 30 orifices on each lid. A gland consists of the central duct with multiple acini, the cells of which synthesize lipid meibum that forms the outer layer of the tear film. So basically, you know that the meibomian gland have a duct and then have a multiple acini, and they produce a meibum which forms the outermost layer of the tear film. So you know that tears has three components: lipid layer, aqueous layer, and the mucin layer. So the lipid layer is secreted by the meibomian gland. Gland of Zeiss are the modified sebaceous gland associated with lash follicle. Glands of moles are modified apocrinoid gland opening either into the lash follicle or directly into the anterior lid margin between the lashes. They are more numerous in the lower lid. So these are all associated with lash follicles, and basically these are sebaceous glands and these are sweat glands. Eccrine and sweat glands are distributed throughout the eyelid skin and are not confined to lid margin in contrast to the gland of mole. Pilosebaceous units comprises hair follicle in the sebaceous gland. So these are the 2.1 eyelid skin. A is showing normal skin is composed of the keratinized squamous epithelium that covers the surface. This pilosebaceous elements are called spacious in the dermis, and a few blood vessels in the sweat glands are also seen. B is showing the dysplasia with loss of cell polarity. C is showing dyskeratosis, a non-surface epithelium cells producing keratin. Parakeratosis means retention of the cell nuclei onto the surface of the keratin layer. So basically these are the pathologies. So what kind of pathology is? Normally the keratin layer does not contain nuclei. So when it contains the nuclei, it is known as parakeratosis. And dyskeratosis means the layer usually does not have a keratin layer, other layers of epidermis. So when the keratin layer is present in other parts of the layer of the dermis, it is known as dyskeratosis. Terminologies are, there are some terminologies that you should be that you should know to identify the kinds of the lesion or to describe the kind of lesion. So clinically, terminology, macule is basically an area of a color change. It is not raised, it is not, so whenever you see some like a white spot in a skin, you it which is not raised or not ulcerated, you can call it simple macule, and it is less than 1 centimeter in diameter. So macule is a localized area of color change without infiltration, depression, or elevation, less than 1 centimeter in diameter. A papule is solid elevation less than 1 centimeter in diameter. So whenever there is a kind of elevation, solid elevation, you can call it papule if it less than 1 centimeter in diameter. Vesicle is a circumscribed lesion containing the serous fluid less than 0.2 centimeter, 5 centimeter across. Bulla is a large, more than 0.5 centimeter serous fluid filled lesion, plural bulla. So vesicle is basically the lesion which contains the serous fluid and it is about 0.5 centimeter, whereas bulla is more than 0.5 centimeter. So pustule is a pus filled elevation. So you know whenever there is a there is an elevation which is pussy, which is less than 1 centimeter in diameter, you can say it pustule. Crust is a solidified serous or purulent exudate. So whenever there is a discharge and that is solidified, it is called the crusting. Nodule is a palpable solid area measuring more than 1 centimeter. So when papule is when we called it is less than 1 centimeter, and nodule when it is more than 1 centimeter. Cyst is a nodule consisting of an epithelial lined cavity filled with fluid or semi-solid material. So cyst is basically an elevation which contain the epithelium, and there will be the material in it like the sebaceous cyst. A solid elevation of the skin greater than plaque is a solid elevation of the skin greater than 1 centimeter in diameter. Scale is a readily detached fragment and of a shed keratin layer. So plaque is basically an is a elevated area, which is like plaque is an area which is formed of in the wounds, like after healing. It can it is basically an elevation from the skin. And scale is a fragment that is present on the skin that can be detached. Scaly skin. Papilloma is a benign neoplastic warty or tag-like projection of a skin or mucous membrane. So whenever there is a finger-like projection and it is a tumor, it is known as papilloma. Ulcer is a circumscribed area of epithelial loss in skin, and ulcer extends through the epidermis into the dermis. So ulcer is basically an area of a tissue loss, you can say. So whenever it only involve both epidermis and dermis, it is known as ulcer. Histologically, tumor strictly refers to a swelling. Thaw is commonly used to denote a neoplasm. Neoplasia, abnormal tissue growth, either benign, localized, non-invasive and non-spreading, or malignant progressive growth with potential for distant spread. So basically the neoplasia is a tumor that can be benign or malignant. Benign is basically which is localized and do not spread, whereas malignant spread and is invasive. Atypia refers to the abnormal appearance of the individual cells, for example, abnormal mitotic figure. Dysplasia is an alteration of the size, morphology, and organization of the cellular component of a tissue. There is a disturbance of the normal structure and recognized layer of the tissue, loss of cell polarity. So the difference between atypia and dysplasia is because the atypia refers strictly to a cells. So whenever there is an abnormal appearance of a single cell, they are known as atypia. And dysplasia when the different layers are affected and there is a alteration in the size, morphology of the component. Carcinoma in situ, intraepidermal carcinoma or Bowen disease exhibit dysplastic changes throughout the thickness of the epidermis. So whenever throughout the thickness of the epidermis there are dysplastic changes, it is known as carcinoma in situ. Hyperkeratosis, acanthosis, basically these are the thickening of the layers of the epidermis. So whenever there is a thickening of the keratin layer of the epidermis, it is known as hyperkeratosis, and where there is a thickening of the prickle cell layer, it is known as acanthosis. And it is very important in the definitions of the tumors. Hyperkeratosis is an increase in the thickness of the keratin layer that appears clinically as scaling. Hyperkeratosis can be a feature of benign or malignant epithelial tumors. Acanthosis, thickening of the prickle cell layer. Dyskeratosis is the keratinization other than on the epithelial surface. Parakeratosis is the retention of the nuclei into the keratin layer. We discussed it already. General consideration, classification, epidermal, adnexal or dermal. So it is basically telling us about the tumors consideration, that we can divide it into epidermal, it can be dermal tumors. The clinical characteristic of benign lesions are a tendency to a lack of induration and ulceration, uniform color, limited growth, regular outline, and preservation of the normal lid margin structure. Biopsy may be required if the appearance is suspicious. Incisional biopsy involves the removal of a portion of a lesion. For histopathology, excision biopsy is performed on a small tumor, and fulfills both diagnostic and treatment objectives. So basically, how do you differentiate that this is a benign lesion or this is a malignant? So benign will be more like benign. It will be of a uniform color. It will have a margins are distinct, and there is no increase in size, and there will be the preservation of the other structures. Whereas in case of the malignant lesion, it is basically aggressive. It will not have a uniform color. shape, size, and it will also destroy the lid margin structure. So how can we diagnose it? We can do it incision biopsy or excision biopsy. So incision biopsy is that we take the part of a tumor, and it is basically done in case of a large lesions. And excision biopsy is done in case of a small lesion. You excise whole of the lesion and then send it for the histopathological purpose. So how will we treat any kind of lesion? So excision of an entire lesion and a small surrounding portion of a normal tissue. Marsupialization involves the removal of the top of the cyst allowing drainage of its content and subsequent epithelialization, ablation with laser or cryotherapy. So you can simply excise it. You can do marsupialization, in which we remove the cyst covering and we allow the things to drain from the top, and other is the ablation with the laser or cryotherapy. So that's it for the eyelid part 1. See you in the next lecture.